is to present you my personal view of what we have learned overall from Transcend. Next one, please. Oh, sorry. Can I change slides from here? Okay. Okay, wonderful. So I would like to start by reminding everyone what we knew when we started, when we decided to create this consortium. And well, I think all of you know that the first experimental attempts to administer insulin orally were already done in the early 90s, which was right after the discovery of insulin and the Nobel Prize awarded for this. So, you know, it is a long history. And only a few decades later, nanotechnology was being proposed as an alternative for delivering insulin, something that was not possible before. I would say that the work by Patrick Cabrera and co-workers is quite relevant in the sense that they showed for the first time the possibility to deliver insulin orally to rats by incorporating insulin within polycyanogranulate nanoparticles. Unfortunately, this data obtained in rats could not be reproduced in dogs. And this is probably the reason why Patrick Cabrera and other researchers think that oral delivery of insulin is the history of continuous ambition and failure. And if we look into the literature, and we did that 5 years ago, of course, we found that there were hundreds of papers claiming the possibility to deliver insulin and other peptides orally. But when we went deep into the literature, we found that only a few papers were really disclosing PK/PD data showing this evidence. And as a matter of fact, there have been a number of clinical trials intended to develop a new product, a new oral insulin product and other peptide products. However, even nowadays, there are only a few insulin prototypes in early clinical trials. So when we decided to create this consortium, we realized that there was a problem. And the problem, according to our view, was that most of the experiments done at that time were based on trial and error experiments. And we thought that was not the right way to go. And we thought that we needed to know more, we need to understand better how nanomaterials interact with intestinal mucosa. We also thought that there was insufficient knowledge regarding the formulation of peptides and proteins using nanoparticles, either for oral administration or for any other purposes. So that was before we started. So what do we know now? I'm repeating what you have heard from my colleagues and students, and I have tried to illustrate here the number of challenges we had to deal with, and I have enumerated them, taking into account the difficulties for overcoming these challenges, according to my view. So we had to deal with the challenge of avoiding the aggregation of the particles. We have to make the particles to penetrate across the mucus. We had to deal with this important challenge, loading the peptide in a sufficient amount, but at the same time controlling its release. And this final challenge has been very critical to be able to incorporate the nanocarriers into a solid dosage form. And finally, we also found that even when the particles were mucodiffusive, and it is true that most of them were able to interact in a higher or lower extent to the underlying epithelium. However, most of them did not translocate across the epithelium. We only found one prototype, and David was talking about it, that could translocate in sufficient amounts across the intestinal epithelium. So I could say that these three first challenges were already known before we started. So this is a confirmation of the importance of these barriers. But for the rest, they were not highly considered before Transcend. So this is illustrated here. So this is why we came with the idea of a rational design. We say we have to tackle all the biological barriers associated to the oral modality of administration one by one. We have to make the particles stable, not to aggregate. They have to penetrate across the mucus, and then they will reach the underlying epithelium. We have been hearing many times this today. And so the key question is, what is the cargo? What is the peptide? Because a very important problem, but very few people talk about, is that the peptide may be lost in their way, either here, through the mucopenetration, and even when they are here, some of the particles may enter the epithelium, only a few of them will cross the epithelium, and they deliver the peptide. So what happens with this peptide? What happens with this peptide is going to be highly dependent on the nature of the peptide itself. We also had to deal with experimental challenges. Noemi was mentioning those, like what kind of technique to measure stability, what kind of technique to measure mucodiffusion, the limited correlation between the data obtained in CACO2 monolayers and also in the human intestinal mucosa, the limited correlation we believe there is between small and large animal models. Unfortunately, we didn't have the time to do the experiments we had planned in large animal models. And something people don't talk about much either is about the protein quantification either in the intestine or in the bloodstream. In all cases, in most of these techniques, a very limiting fact was the one related to the labeling of the particles. You have to label the particles to track them, either with a fluorescent marker or with a radioactive marker, and this poses important problems, hurdles, and complications for the interpretation of the data. In any case, I truly believe that we have gone from the old view that assumed that particle diffusion and transport across the intestinal mucosa would occur with monocomponent systems, let's say solid lipid nanoparticles, PLG nanoparticles, chitosan nanoparticles. That was the old idea. Now we think that we have to define, we have to design in a rational manner these nanocarriers and to make them adequate in order to, and they may incorporate stabilizers, penetration enhancers, and enzyme inhibitors. And these nanocarriers should be adaptable to a solid dosage form. So this is the advances we have made. As you could hear from Andreas and others, we have tested thousands of prototypes, thousands of formulations coming from different technologies, so different kinds of nanoparticles, nanocapsules, nanoemulsions, mono multi-layers assemblies, and made of many different materials, such as chitosan derivatives, cyclodextrin derivatives, arginine-rich polymers, lipids, metals, all kinds of materials, all kinds of structures. And we have loaded within these nanocarriers different peptides, a number of anti-diabetic and anti-obesity peptides, and also an anti-pain peptide. All of them with different properties, physicochemical properties, so this has generated a huge amount of information in terms of peptide formulation. So we screened these prototypes, as Andreas explained, and we selected 13 prototypes that seem to fulfill all the characteristics of the target product profile in terms of size, stability, mucodiffusion, control release, everything. And we analyzed the PK/PD behavior of these 13 prototypes, and we have selected 6 prototypes that have been validated by Sanofi for the same kind of analysis, for the PK/PD analysis. So hopefully, we hope that from these 6 prototypes, 1 or 2 may be promising vehicles, maybe for insulin, for other peptides, or even not for systemic delivery, but also for local delivery. And this is what Patrick was mentioning before. We have to learn, we have a lot of information on how the particles interact with the intestinal epithelium. So some of these prototypes would be good for systemic delivery, but others, like this one generated in my lab, may be good for the treatment of local diseases. What you see here is a cross-section of the intestine, and in green you have our nanoparticles associated to the mucosa. So we are now trying to pursue it with this kind of technology for local delivery of proteins and monoclonal antibodies to the GI tract. So what is the future? We believe that the future is on the use of novel materials. We have been modifying chitosan, we have modifying cyclodextrins. We believe we need to modify the materials in order to make them more adaptable for the peptides. But we also believe that we need to modify the peptides to make them adaptable for the delivery carrier. So in both sense, modify the materials, modify the peptides. Of course, we need new analytical tools, although we have generated a few already in this consortium. we think that the rational design, because we are getting to know more and more about the interaction with nanomaterials, with biological surfaces, we are more ready to go for a rational design according to a target product profile and with the early definition of the quality attributes. We have to keep in mind from the beginning of our experiments, the final dosage form. Some people were mentioning that, but we experienced great difficulties that we didn't expect at the beginning when we tried to convert our nanocarriers into a powder that could be put into a capsule or into the sigmoid technology. So yeah, the other recommendation we have got from several people, from our advisors, is that to go to human tissue experiments as soon as possible, because the information coming from CACO2 cells is kind of, every particle can enter CACO2 cells almost. So the human epithelium tissue is much more restrictive and probably more realistic, and also to go as early as possible with large animal models, because we do know the limited reproducibility of data from small animal models to large animal models. So at the end, we hope that we have a new nanomedicine candidate that eventually will go into the clinical development phase. We will see, because the experiments haven't been ended yet. They will end in May, although we are running out of money this month. We have to justify this, but we will continue doing some experiments that are halfway done, I would say. Okay, so from the transversal point of view, the students mentioned what they learned. I have to say that as a coordinator, I learned a lot. First of all, I learned that the coordination of a large European consortium is very complex. The complexity, I could never imagine that was going to be so complicated. To persuade people to collaborate, that was extremely hard. Although this is an assumption, we want to collaborate, but then the effective collaboration, especially in the way we defined these consortiums, this consortium, where there was a reference center for CACO2, a reference center for in vivo, a reference, that was very difficult, but we did it. And I found that understanding the language, the communication language of other collaborators was difficult, but we learned in the process. I always thought that empathy was very important in order to persuade people to exchange information and to go in the right way, and to learn new ways of communicating. As my student Matilde say, resilience. At the end, we gain resilience. And generosity. I always tell my students, generosity is always very important, especially when you want to collaborate with people. You always think that you are doing the right thing and the collaborator is not doing well. So you have to be very generous to realize that the difficulties come from both sides. Tangible outcomes. Well, 51 researchers have been working in Transcend, 15 PhD students, 25 exchanges of researchers between 8 different labs. We have organized a conference together with the Alexander Consortium. David Redding organized a CRS workshop on peptide delivery. We have organized a number of webinars and videos. We have produced so far 300 documents, 50 publications, and as far as I know, I think we will produce at least as much in the coming year, because most of the publications are meant to be written, which is logical because you need to generate the data. Especially our publications will have many different authors from different backgrounds. So writing these papers is already being, we know that, quite difficult, but they are very good papers. And we have also produced a monographic issue on oral peptide delivery in the Advanced Drug Delivery Review journal, which is the highest impact factor journal in our field. Oh, sorry, this is not information we wanted to. Okay, so I think with this is all. I talked more than 10 minutes. I think the students were allowed to. And so with this, we close the session.